COPD stands for what? Chronic obstructive pulmonary disease. So what is COPD? It's a chronic obstructive pulmonary disease. That's it, right? It's an obstructive thing, just like asthma. It's obstructing, it's getting in the way. There's an impeding blood O2 flow into the patient. Okay, there's two varieties. We got bronchitis and emphysema. Those are our two different COPD types. And it's a really significant reason for disability, significant reason for death, significant reason for mortality and decompensation, right? Sorry, the other way I was going to say is a significant reason for hospital admissions. It's a very common reason to get hospitalized, and just like with asthma, we want to avoid triggers, right? We want to prevent them from getting hospitalized. All right, so how do you get risks of COPD? When does that happen? Happens somewhat for some reason in the Midwest states. All right, happens in Puerto Rico more than anywhere else. Cool, but as far as genetics, alpha-1 antitrypsin is a specific thing that you'll see when you have a COPD in a young patient. COPD usually always happens in someone that's like late 40s, 50s, 60s, and that usually always happens later in life. You never see COPD develop in like 20 or 30-year-olds, whereas asthma can happen when? That happens all the way down to peds, right? And then it can't progress to adulthood. Whereas COPD is on the back end. It's going to cause more of your older adults, middle-aged to older adults to succumb to COPD. And the most common reason for COPD is smoking, right? Second place is air pollution. So we got really bad air pollution right here. That's leading to COPD to develop, right? All this toxic fumes getting into the lungs, that's going to lead to our lungs to respond, and eventually they can develop COPD from that. Okay, occupational dust, chemicals. So they work at a paint refinery, they work at a chemical plant. These are things that would say, oh, they're at high risk for COPD. Okay, they need to wear the protective equipment before they do their job. The other thing is low socioeconomic status and non-GED educated. Those are more at risk, and usually that's probably associated with where plants are developed and where people who smoke and access to things that would prevent inflammation, like a good diet. That would be a thing that would cause a risk for COPD. And having an asthma history. There's such thing of having asthma and COPD. That has a much, much higher mortality. All right, so it's airflow can't get into the lungs. Why can't it get in the lungs? Well, there's two types. There's emphysema and bronchitis. So emphysema is when you have the lower airways get weak. Okay, so here's our emphysema patient. You can see this little weakness right here. So the air could get in just fine. So the air comes in, inhale, and then it's time to exhale, it closes shut. So now the air is getting trapped. Right, so the air is trapped there, and that air being trapped is going to get more trapped over time, more air. You really can't get that air out, and when you get air out, that's how you get CO2 out. All right, so these guys are CO2 retainers. These guys are all about the CO2. They can't get CO2 out. They air trap. The lungs actually get bigger and bigger and bigger, and they get like barrel chested because they're full of air all the time. So that's a classic emphysema kind of patient. And why did that terminal bronchial from normal, see there's normal lungs right there, why did that terminal bronchial get so weak? Well, with all that smoking, all that pollution, all those triggers that got into the lungs, it caused our neutrophils to get activated. And what our neutrophils do, they release this enzyme called elastase, and that elastase will break down that distal lung, the distal lung tube. Right, so that breaks it down, breaks down the muscle, makes it less elastic, so it can't stay open all the time. Okay, so that then leads to a trapping of air. And you can see alpha-1 antitrypsin, that's a specific thing that inhibits elastase normally. So obviously if you have that deficiency, you're going to have more elastase, more breakdown. That's what happens in younger or older people. In younger people. All right, so we have this chronic air trapping, chronic high CO2, chronic respiratory acidosis. These guys usually always sit at a CO2 greater than 45. That's their thing. And they're going to compensate how? How do you compensate with that elevated CO2? Bicarb. Bicarb is going to go what? Up or down? Up. So bicarb goes up. Bicarb is a base. CO2 is an acid. If I'm getting more acids, I'm going to add more base. Right? So that way my pH is normalized. Okay, so the other piece, when you have all this air trapping, the lung can pop. So that's called a spontaneous pneumothorax, right? So it just pops one day, bam, pop, right? And then the other lung pops, and the other lung pops, and the other lung pops. They have these chronic spontaneous pneumothoraces, and it's usually end-stage COPD. That's not a good finding. All right, and then now chronic bronchitis. Chronic bronchitis is where you have chronic distal lung, right? The distal lung is chronically getting inflamed and chronically producing mucus. So all this mucus keeps getting produced, all this airway constantly gets inflamed, and then now we have this chronic cough with that irritation, with that mucus in the distal lungs makes you cough. Just like with our asthma patients, they cough because of mucus. These guys are making mucus all the time. There's something called bronchiectasis, which is a complication of this. With all that mucus, it kind of distends the bronchus. So actually all this mucus getting produced actually distends it so much that the airways can get bloated with mucus. And these guys are like putting out like solo cups worth of mucus per day, right? Like 400 to 800 cc's of mucus. So these guys are, they're not that fun at parties, but they'll have their solo cup with them. All right, but these guys have a lot of cough, a lot of sputum, and they're going to, all that sputum in the way, is that going to be easy to get oxygen in? So these guys have low oxygen states. They're chronically with low oxygen. They're chronically a little bit cyanotic. They're chronically having a complication that happens with low oxygen, which is called clubbing, right? Not clubbing with your solo cup. So your symptoms. So the classic is probably not politically correct now to call them blue bloaters, but they chronically are cyanotic and they're chronically bigger in size, right? So they are having a low oxygen state, which is leading to the cyanosis, and also a characteristic of chronic low oxygen is clubbing. So clubbing is where you have your fingers are, I put a picture here, I should put a picture next time, where your fingers, here's your finger here, finger joint, right? There's the nail there, and the nail bed is kind of puffy. So it looks like they have almost look like edema of their fingers, okay? So emphysema patients, they have high or low CO2. They have high CO2. So these guys are always working really hard, their airways are full, and they're trying to take all that air in, and that's going to cause a thin appearance and cachectic appearance, which cachectic is just a fancy word for saying thin, and it's because their work of breathing is so much. All right, their barrel chest, as we mentioned, their AP diameter is very widened, right? So they have a wide barrel chest. When you see this in real life, it's like, oh yeah, that chest is much more swollen than it should be. That's because of all that air trapping over time. Okay, they can do it. They can see that in chest X-ray. Also in chest X-ray, you can see the lungs are super big, right? They're all air trapped. The diaphragm gets flattened. The diaphragm should be nice and curved. So they have a difficulty getting air into their chest because they're only working with this much movement, right? So now their work of breathing is a lot higher, right? And then we got dyspnea, right? Because they're short of breath. They have all this air trapping. So one of the things we teach them is pursed lip breathing. The reason why that distal bronchial collapsed is because it wasn't being maintained open, which is a bad excuse. But anyways, if you do pursed lip breathing, that's going to maintain air pressure at all times, right? You're keeping those airways open, and that's going to allow those airways to stay open, and hopefully you can get rid of CO2. Okay, so our blue bloater, this guy is obese. They have copious amount of secretions, and they have a lot of wheezing because of all that, all those secretions, and they're chronically hypoxic. And we know the symptoms of hypoxia, right? They're going to be getting short of breath. They're going to, which is dyspnea. They're going to start getting SNS signs. They're starting to get fatigued, anxiety, and then cyanosis, right? You have chronic low O2. Your body's going to start making more RBCs, and that's called polycythemia. That's a chronic complication of chronic bronchitis. And these usually happen at the same time. So, but like classically, sometimes you'll see a classic patient that just has emphysema, but usually people have a combination of both. All right, so diagnostic tests. So it's the same thing. We're going to do the PFTs, right? And are they going to be able to get air out of their lungs effectively? If the distal part of their lungs collapses, can they get air out that great? Or if they have mucus at the base of their lungs, can they get that air out effectively? No. So asthma was less than 80%, and COPD is less than 70%, right? So the PFTs, we have less than 70%. So the forced vital capacity is how much air they can get out. And then we say, well, how much can you get out in 1 second? Let's compare the two. Let's do a test. If you can get out 5 liters, and then you can only get out 3 liters in 1 second, that's 60%, right? So that you have COPD. And with asthma, you get bronchodilators, and it can help, right? But these guys, they have lungs that they have a structural deficiency. So that's why giving bronchodilators is not going to help their test score. So CBC, you might see that polycythemia with the extra RBCs getting produced. X-ray, we said the AP diameter. So if you look at a side view of them, here's the anterior, there's the posterior back there at the plate. They put the plate behind them. You're going to see a really, really wide chest. Okay. Also, we do X-rays to make sure there's no pneumonia happening, no PE happening, right? So PE is a significant side effect or a significant reason for patients to get hospitalized with COPD. ABG shows respiratory acidosis, especially with our patient with emphysema, right? Emphysema is the one that has what? High what? High CO2, right? So the respiratory acidosis is going to, that CO2 is going to go up and up and up in 60, 70, 80, and really, really bad COPD. So how do we know if they're in trouble, right? So that's what we do. We can calculate what their baseline CO2 is. Say, hey, you have a CO2 of 80. Is that where you live at home, or is that are you in trouble and about to decompensate, right? So you can take what their bicarb is, and you can say, because your bicarb is what compensates, right? And bicarb takes like 2 to 3 days, 2 days tops to really start equilibrating things in our kidneys. So we can take the bicarb, multiply by itself, by half of itself. So your bicarb's 30, right? And we do 30 times 1.5 is 30 times half of itself, right? Or plus half of itself is what? 45. And then we add 8. Right, so 53 plus or minus 2 is where their CO2 should be. So if they have a CO2 of 80, that's really bad, right? But let's say their bicarb is 40. What's their baseline CO2? At 40 plus half of itself, right, that's 60, right? Plus 8 is 68, plus or minus 2. So they're 66 to 72. That's where their CO2 is at baseline. So that becomes a problem when we say, oh, their CO2 is 55. Let's go ahead and try to fix that some more. It's like, no, that's actually too low for them, right? And when that happens, they can actually stop breathing. So that's the problem with blowing off too much CO2. And that's what happens when you give someone too much oxygen with a COPD patient. So too much oxygen with a COPD patient can displace, right? Because your hemoglobin decides, do I take O2 or CO2? Right? So it takes the O2 and it displaces it, and then you can have this lack of breathing because all the CO2 all of a sudden went up. When your CO2 goes up, CO2 is a natural anesthetic. It's going to make you sleepy, comatose, right? So that's why we don't give too much oxygen to our COPD patients. And specifically for patients that are hypoxic all the time, just 80 to 92% is perfect. That's where they should be, right? It's called permissive hypoxemia. We allow them to be a little bit hypoxic, 80 to 92% for COPD patients. And then the other thing is like, well, do I give oxygen to every COPD patient? Absolutely, to a saturation of 80 to 92%. I'm not going to overdo it and go 94, 96, 98. I'm not going to let them sit at 86, 84. I just want them nicely 80 to 92. I'm going to give enough oxygen to make that happen. Okay. There's also the thing, well, if you give too much oxygen, it removes their stimulus to breathe. That is completely false. It's been disproven like 25 years ago. That's not a thing at all. Okay, it's more what I talk about, this displacement of oxygen. Also, when you put all the oxygen into the patient's lungs, it displaces all the dead space, and they can get a hypoxic vasoconstriction. So it's a whole. I explain all the reasons there. If you want to know more, let me know. We'll talk about it. All right. So what's the treatment for COPD? All right. It's got 2 slides left. Goals are again to avoid exacerbations, avoid them from getting hospitalized. So how do you prevent them getting hospitalized? We've got to make sure they are taking their medications. So just like with our asthma patients, they have the inhaled corticosteroids are going to be kind of a mainstay. So inhaled corticosteroids, I have them here somewhere, but those are going to be our go-to. We also have bronchodilators. And remember, we have bronchodilators, we have SABAs and LABAs, and SABAs are going to be our go-to agent, PRN. If we have bronchoconstriction, we can take some SABAs to help that out, right? Smoking is an important reason for COPD, so we give some smoking cessation. That's going to be an important thing to prevent further COPD exacerbations. It decreases mortality by 18%, which is an incredible feat. Okay. Sometimes they need oxygen, and if they need oxygen, we need to make sure they're wearing their oxygen and also make sure they're not smoking. Because what does smoking and oxygen do? going to be a fire, all right? It's going to be an explosion. So oxygen is another important thing to help fix their COPD, or help prevent COPD from getting worse and worse and worse, okay? So they got to wear their oxygen how long? About 15 hours per day. That's going to be the go-to. So if they're just sleeping overnight with their oxygen, I only wear it when I go to sleep. Well, who sleeps 15 hours besides a teenager? Not many, right? So we want to make sure that they are wearing their oxygen appropriate amount of time. Okay, and of course, do not smoke with oxygen. If they are smoking, we have this 5A strategy where you assess, what are you doing, how much are you smoking, why are you smoking, assist them with, social support, with medications even, to stop this from smoking from continuing, because that's really what's going to fix it. Giving bronchodilators and steroids is not going to fix the problem, right? That's just going to be, that's just putting a Band-Aid on the symptoms. Pursed lip breathing is an important teaching piece to look at. So if they are, they have COPD, we can teach them pursed lip breathing, right, to help fix when someone is hypoxic, or when someone is in distress. All right, so then COPD exacerbation, we'll talk on the next slide. That's the ultimate thing that will happen. That's the most common reason for them to come to the hospital. But other side effects, other significant things, we talked about pulmonary pneumothorax. Pulmonary pneumothorax, a spontaneous pneumothorax. That is when your lungs just pop. From which one? From emphysema or bronchitis? Emphysema. With all that air trapping, it can trap and trap and trap and then pop. Okay? So they might need a chest tube to fix that. And we'll talk about chest tubes in Med-Surg 3. And pulmonary hypertension. They have all this widespread low oxygen. And who has widespread low oxygen? Emphysema or bronchitis? Bronchitis, right? They got widespread low oxygen. Everywhere in your body, when you have low oxygen, you vasodilate. That's what you do, right? That's going to get more blood flow. In the lungs, though, if you have like a pneumonia on your right lung, it's like, well, shoot, why am I going to open up blood flow to that right lung? We're going to shut you down and reroute blood flow to the other lungs that work. Well, what if your low oxygen is everywhere? Now, they don't have a system to fix that, so everything vasoconstricts. That puts extra pressure on which side of the heart, left or right? Who pumps blood to the lungs? The right. The right does, right? So right does correct. So the right will pump extra, and now has all this extra work, and now you get right heart failure symptoms as a side effect, with which that explains it right there. I got dependent edema, JVD, I got hepatosplenomegaly. Those are all right heart failure symptoms. Okay, and then polycythemia we touched on, right? Their H&H goes up because they're hypoxic all the time. And then we have all this inflammation is not great. They can get lung cancer. Lung cancer is a #1 cause of cancer deaths, but also it's 90% are due to smoking, and then COPD is going to exacerbate that. Okay, what else? So then COPD exacerbation. That's where they have some kind of trigger. Just like asthma exacerbation, they have a COPD exacerbation due to flu or a trigger of some sort, or not taking their medications. And 30% of the time, no idea what happened. But PEs are up there. Pulmonary embolism can be a significant reason for a COPD exacerbation. And why would someone who's smoking be at risk for PEs? It's part of whose triad? Virchow's triad, right? Where we got this chronic damage to our vessels, right? And then we got treatments. So treatments is, again, O2. We're giving the steroids, just like with asthma, okay? And we might have to put them on a ventilator. Before we put them on a ventilator, though, we can, we have these other devices you might see patients on. They're called high flow devices, and they put in oxygen, but they also put in a whole bunch of flow behind it, and that flow is going to open up those airways and help deliver the oxygen that's needed, right? Or just the airway pressure they need. And we can upgrade them to BiPAP. That's usually probably getting worse. And then after that fails, we can then progress them to an intubation. Okay, this is all called positive pressure ventilation, where we positively put pressure behind each breath. Okay, so that's the idea with COPD exacerbation, is you're trying to avoid it with vaccines and trying to make sure they're quitting smoking, make sure they're wearing their oxygen, make sure they're taking their preventative medications to prevent a COPD exacerbation. All right, so that's it for respiratory.